What's up, everybody? Dr. Bonzo back again with a quick hitting high yield review on a medical topic. Today's topic is hypercalcemia. If you enjoy this kind of content and want to hear more about it, don't forget to hit that subscribe button and also like and leave me comments if you have any feedback. So today's topic is hypercalcemia, high calcium. Now this is presented on tests in one of two ways, either as a hypercalcemic crisis or as an incidental finding in an outpatient setting. Hypercalcemic crisis should be obvious. Remember that rhyme a lot of y'all learned in school, the bones, moans, abdominal groans, psychic overtones. That's how these patients will present. Their calcium levels will be really, really high, like 13, 14. They'll have maybe pancreatitis, have an elevated lipase level, maybe have some delirium or confusion, altered mental status, maybe have some bone pains. In those situations, they'll ask you, what's the initial thing you want to do, or what's the first thing you do? The first thing you do is give them fluids. Normal saline IV. They'll try to trick you. They'll give you other options that will make hypercalcemia get better. They may talk about using loop diuretics or giving the patient IV furosemide. They may also talk about giving IV bisphosphonates such as zoledronic acid or pamidronate. Those things will lower calcium levels, but that's not the first thing you do. First thing you do is always give fluids, give saline. If you give diuretics first, you actually might dehydrate the patient even worse and make their situation worse. So don't forget fluids. As an outpatient setting, you get that incidental lab finding. On a test, it'll usually be presented as a mild elevation. So in this situation, the calcium level might be 10.8, 11, something like that. In those situations, what's the first thing you do? Stop the thiazide diuretic. Didn't see that coming, did you? So thiazides can raise your calcium levels just like loop diuretics can lower your calcium level. So if somebody has outpatient elevated calcium level, stop their thiazide diuretic, have them come back in a few weeks, repeat the calcium level. If they come back and the calcium level is still elevated, or if they're not taking a thiazide diuretic, then your next step is to order a PTH level. You also may see that written as an intact PTH level or an i-PTH level. So the next step you have to know that will be presented on test is sometimes they'll actually give you the PTH result and you have to know what to do with that. So if the PTH level is high, think primary hyperparathyroidism. Your parathyroid glands just spitting out PTH uncontrollably. Maybe there's an adenoma there that's making it do it. And your body is saying, hey, my calcium levels are high. I don't need any more PTH. But your parathyroid glands, they don't care. They're just spitting out more and more PTH. So in that situation, high PTH, high calcium, think primary hyperparathyroidism. Second thing is, what if the PTH is normal? Think familial hypocalciuric hypercalcemia. So remember that weird condition you probably learned about in school where even though your calcium levels are high, your body normally would try to excrete a bunch of calcium to lower that level. But in this situation, your kidneys can't quite pull it off. So those patients actually will have low calcium levels in their urine, even though they paradoxically have high calcium levels. So in that situation, your next step would be to order a 24-hour urine calcium level. Last option is, what if the PTH is low? Think malignancy or cancer until proven otherwise. So remember, in some cancers, you have that paraneoplastic syndrome where your body makes that PTH-related peptide, or the cancer does. And so you might see it also written as PTH-RP. So the PTH-related peptide functions just like PTH. It strips your bones, makes elevated calcium levels, but your normal native PTH levels are actually low because your parathyroid glands are saying, well, we don't need any more PTH. This cancer is making all the PTH we need, so we're going to actually drop our PTH levels low. So in this situation, again, outpatient elevation of calcium levels, maybe the patient's asymptomatic, mild elevation. First step, stop the thiazide diuretic. If they're not on a thiazide, or if their calcium level still is high after the thiazide is stopped, next step is to order a PTH level. If PTH is high, think primary hyperparathyroidism. If it's normal, think familial hypocalciuric hypercalcemia and get a 24-hour urine calcium level. If the PTH is low, think cancer or malignancy until proven otherwise. All right, last quick point is, in terms of primary hyperparathyroidism, when do you refer somebody to your surgeons for removal of the parathyroid glands? Typical indications for surgery are somebody who presents with primary hyperparathyroidism under age 50, somebody who has kidney stones, somebody who has a persistent elevation of calcium that's more than 1 gram per deciliter above their normal value. If any of those things are present, get them referred over to your surgeon. All right, Dr. Bonzo, once again, 5 minutes or less, hypercalcemia. Don't forget to subscribe.